Assalamualaikum warahmatullahi wabarakatuh. To our lecturer, Mr. Muhammad Afizi bin Mahmud, we would like to present our group presentation. The topic we choose, which is Lung Scintigraphy. Okay. This is list of our group members. Started with me, Damisa, followed by Muhammad Azwan, Muhammad Hafiz, and Siti Nohaja. This is list of content that we will present. Started with indication, followed by technique, radiography appearance, and reference. Okay, what is lung scintigraphy? It's also known as a ventilation perfusion, which is a VQ scan. It's an examination to measure the blood and air supply to the lungs, best non-invasive test to establish pulmonary embolism. Okay, for indication, okay, ventilation perfusion, which is VQ scan, is a scintigraphic examination of the lung that evaluates pulmonary vasculature, perfusion, and segmental bronchoalveolatory ventilation. Okay. Most commonly, VQ scan to diagnose the suspected of pulmonary embolism. This examination has been also to monitor pulmonary function of the lung transplant, to provide preoperative estimate of lung function in lung cancer patient when pneumonectomy is planned, to evaluate right to the left shunt, to conduct serial assessment of inflammatory lung disease. Next technique. Okay. Normally, there's 4 types of radiopharmaceutical that used for ventilation lung scan. First is xenon 133. Xenon 133 is a radioisotope widely used to perform ventilation lung scan. Has a half-life 5.3 days. Is a beta emitter. The principal photon energy is 81 keV, which is significant attenuation effects. Normally performed before perfusion lung scan because the counter scatter from higher energy MAA, which is 140 keV, will interfere with the ventilation images. The dark dose is 10 to 20 millicurie, which is 370 to 550 megabecquerel. The next, xenon 127. Xenon 127 is a cyclotron produced isotope with a physical half-life of 36.4 days. The principal photon energy is 203 keV, 170 keV, and 367 keV. So because it's a higher energy, so it can be performed if needed after the perfusion scan. Unfortunately, it's expensive and limited availability. The usual dark dose is 8 to 15 millicurie, which is 296 to 500 to 55 megabecquerel. Okay, the third one is Krypton 81. It's another noble gas used to ventilation scan. Okay, it's a short half-life, which is 13 seconds only. Okay, it's produced from a rubidium 81 to Krypton 81 generator. So it decays by isometric transition. The photon energy is 191 keV, so it's allowed for ventilation scan. If needed, after an abnormal perfusion scan. The generator is expensive and limited in use. A dark dose 10 to 20 millicurie, which is 370 to 740 megabecquerel. Okay, the fourth one is technetium aerosol. Okay. Ventilation scan also can be performed using aerosol rather than gaseous agent. Okay, so radioisotope label aerosol are produced by nebulizing radiopharmaceutical into a fine mist that is inhaled. Okay, the DTPA is commonly used for radioaerosol. Okay, the advantage of the technetium aerosol, they are widely available, is inexpensive, and have a 140 keV, which is ideal for gamma camera imaging. The process is inefficient, which is 2% to 10% of the aerosol radioisotope is deposited within the lung. So of 30 millicurie of nebulized DTPA, only 1 to 2 millicurie deposit within the lung. Okay. Last one for the perfusion lung radiopharmaceutical used for the perfusion lung scan is MAA, which is a microexaggerated albumin. Okay, can be perform most perfusion lung scan prepared by heat denaturation of human serum albumin. Particles are irregularly shaped molecule, 20 to 40 micron size range within 90% of the particles between 10 to 90%. Larger than 150 microns not be injected, can be because it can be obstruct the arterioles. Biological half-life of MAA particles in the lungs is 2 to 9 hours. The physical half-life of MAA is 6 hours. Okay, that's all. I will pass to the next presentation to my colleague. Thank you.
Assalamualaikum. My name is Muhammad Azwan. I will continue the presentation with the topic radioactivity administered. There are two ways of radioactivity administered. The first one is a breathing at the lung ventilation phase, and the second one is IV injection in the lung perfusion. There are three methods, namely. The first one is use aerosol technetium-99, and the second one is use the gas like a krypton 81M and xenon 133. The radiopharmaceutical used for aerosol is a 99 technetium DTPA or 99 technetium dry particles. This is the advantage of aerosol ventilation imaging. Aerosol is cheaper than greater availability. Radioactive gas has a short half-life and often unavailable. Image can be obtained in multiple projection or with spec to match those obtained for perfusion imaging. Disadvantage is image quality is not good as radioactive gas. Next is gas. The gases are radionuclides such as krypton 81 and gas produced from a rubidium 81 generator. The patient breathes a mixture of 81 and krypton in air or oxygen produced by passing a stream of water humidified air or oxygen through generator. We also use the xenon 133 radioisotope widely used to perform ventilation lung scan. This is an example where the patient wears a mouthpiece and nose clip. Each image looks different according to the level of formulation until washed out. Inhalation, single breath. Patient is instructed to take a deep breath and exhale. The gas is introduced into the system and the patient is instructed to take a deep breath and hold it for as long as possible. In equilibrium phase, the patient is instructed to breathe normally through the delivery system containing the gas and oxygen for 2 until 3 minutes. The ventilation image acquired in the same position with 6 views, which include 4 dynamics image like posterior, oblique, lateral, and anterior. It means have a 6 view, posterior, anterior, both posterior oblique, and either both anterior obliques or lateral views. For washout phase, the gas is vented into the trap as the patient continues to breathe room air mixed with oxygen. Aerodynamic images, 50 to 60 seconds each, are required for 5 minutes until washout complete. The last is IV injection. In supine position, patient is instructed to cough and take a deep breath. Then the technetium is injected slowly into the vein during the 3 to 5 respiratory cycle in the perfusion phase. Injection through the while the welling line port need to be avoided because it containing filter. Okay, the next topic is a patient preparation for performing the examinations. One is a precaution. If you are pregnant or think you may be pregnant, please check with your doctor before scheduling the exam. We will discuss other options with you and your doctor. Okay, the breastfeeding. If you are breastfeeding, you should notify your healthcare provider due to the risk of contaminating breast milk with the tracer. For clothing, you may be asked to change into a patient gown. A gown will be provided for you, and locker are provided to secure your personal belongings. Please remove all piercings and leave all jewelry and valuable at home. Generally, no prior preparation for fast such as fasting or sedation is required prior to lung scan. For allergies, notify the radiologist or technologist if you are allergic to or sensitive to medications, contrast dyes, or iodine. The injection of the radiotracer may cause some slight discomfort. Allergic reactions to the radiotracer are rare but may occur. Then the chest X-ray may be performed prior to the procedure if one has not already been obtained in the previous 24 to 48 hours. This is because the radiograph will be used together with the scintigraphy image in order to rule out the pathology. Okay, that's all. Thank you.
Assalamualaikum and have a good day, Sir Hafizi. I would like to continue this presentation, topics of lung scintigraphy for the type of collimator used. Um, for the lung scintigraphy, have a three procedure for the planar ventilation study, planar perfusion study, and VQ spec. So these three of procedure using same collimator is LEHR. So LEHR is uh, low energy and high resolution collimator. So this procedure, the collimator was used. Collimator LEHR have higher resolution. So this collimation have more holes and they are both smaller and deeper. So for the planar ventilation study, the camera was equipped with this low energy high resolution collimator. Also, planar perfusion study, the camera also was equipped with this low energy high resolution LEHR collimator. So for these two procedures, using the same camera with equipped with this LEHR collimator. But for the VQ spec, the procedure you are using a dual head gamma camera, which is the camera was equipped with this low energy high resolution collimator. So the spec procedure is using dual head gamma camera but still using low energy high resolution collimator. The three type of this procedure are using the same collimator, the same of type of collimator. Next, I will continue to the next point is image acquisition. For image acquisition is image processing of data collection from the camera. So the image will appear based on acquisition pixel size and time acquisition. So for the procedure planar ventilation study, the size of pixel is 256 times 256 pixel matrix with total image acquisition was 90 seconds. In rare cases, it was prolonged until up to 180 seconds to get the image. So for the planar perfusion study, the size pixel is 256 times 256 pixel matrix also, and it was selected for accumulation at least 600,000 counts per image. to get the image for planar perfusion study. And the last one is VQ spec. The pixel size was using is 64 times 64 pixel matrix was used with total acquisition time of 20 minutes. For this VQ specs, have a 128 projections, which is 64 per head camera were acquired. So these three image acquisition based on pixel size and the time of getting the acquisition for the image processing. Thank you for me, and I will pass the presentation to the next member, team member. Thank you.
Assalamualaikum warahmatullahi wabarakatuh, and very good morning. My name is Muhammad Hafiz bin Abu Bakar. As we know that the lung scintigraphy is an examination to measure the blood and air supply to the lungs. It is the best non-invasive test to establish pulmonary embolism. Let me continue the presentation with the radiographic appearance. Okay, this is the bronchopulmonary segment, and the bronchopulmonary segment are the largest functional division of the anatomical lobes, each receiving their own air and blood supplies. So what we can see from here, the difference between the images and the lung scintigraphy. This is the left pulmonary oblique, and we know that from the radiograph is different with the images here, and this one is a posterior. You can look the difference between the left and right. Okay, below is the VQ spexity in COPD with and without emphysema and in a healthy volunteer. So this is the ventilation, and this is perfusion, and this is a CT scan. You can see the VQ spexity with midline inhomogeneous ventilation and perfusion, and the normal low dose CT findings in the middle of each healthy volunteer with a normal lung function. Okay, here we can see the patient mismatch in mixed emphysema and fibrosis. Abnormal VQ specs with ventilation to the periphery and the perfusion to the central part of the lobes. Right right and left lung distribute to the perfusion is 50-50, and the ventilation is 64 and 36. Patient with the restriction and severely reduced DLCO. So from the HRCT show that extensive paraseptal and central lobar emphysema, 40% emphysema, and basal fibrosis. Okay, let me look at the C patient. This triple match in small airway disease. Several abnormal VQ spexity with multiple match patchy ventilation and the perfusion defect, and matching with areas of mosaic perfusion on the low dose CT in subject with severe airway obstruction. For the HRCT show that extensive area with a low attenuation and moderate perfusion. Okay, when we look at the patient number D, triple match in emphysema, severely abnormal VQ spexity with match reduced ventilation and perfusion, which is worse in the lower part of the lung. matching with the CT finding of emphysema, 30% of emphysema. Patient with severe airway obstruction, hyperinflation, and low diffusion capacity due to the emphysema. And patient have alpha 1. We go to the next. Okay, let me see the VQ spexity in this patient with the severe COPD with the emphysema before and after lung volume reduction surgery. Severe reduction of ventilation and perfusion in the upper part of the right lung corresponding to the central lobular emphysema seen in the HRCT. After lung volume reduction surgery of the right upper lobe, ventilation and perfusion improve in the right lung, which also is less hyperinflated. You can see from here, this before and then after. Okay, from the HRCT, we can see the red marking of emphysema, which is that 47 emphysema and 62 in the right and the 20% in the left lung. Okay, I think that's all from our presentation today. I hope you all can get information from the presentation today. And thank you very much. And Assalamualaikum warahmatullahi wabarakatuh.